Hi, this is Dr. Dan Sullivan with the Sullivan Group, and this is a short demonstration of a new, first of its kind program called ED Guidance, co-developed by Nuance and the Sullivan Group. ED Guidance lives inside of Nuance's Dragon Medical Advisor and evaluates your medical record real time during the patient encounter, offering guidance focused on improving diagnostic certainty, reducing medical errors, and keeping our patients safe. ED Guidance works with all of the popular electronic health records. ED Guidance lives outside of and communicates with your electronic health record. You may place it in any location that's convenient for you. You can float it. I like to put it on my second monitor. For this presentation, I will dock it right. ED note: I will use some macros and some dictation to move as quickly as possible through this chart. The patient is a 20-year-old male with a chief complaint of back pain, period. ED Guidance will now evaluate the medical record and, through a series of algorithms, provide a list of conditional clinical drivers that TSG has developed over the last 2 decades. Clinical alignment around these drivers is known to be associated with a reduction in medical errors and malpractice claims. After a review of tens of thousands of ED claims, these are the critical elements that can lead to a correct diagnosis, but are often overlooked or missed, resulting in medical error and the failure to diagnose. Think of ED Guidance as a checklist. There's nothing required, no hard stops, just suggestions that could make a significant difference. This patient presents a good example. This is an actual case. What's the error profile here? It is anchoring on musculoskeletal back pain and failing to consider more serious problems in the differential. Back pain history 1. The onset was gradual, so that will retire. There's no movement or migration of the pain, so that will retire. Both typical for musculoskeletal pain, but now let's give the patient something a little bit different. The pain is located in both the lumbar and thoracic areas, period, new paragraph. So location will retire, but the algorithm will now suggest consideration of a spinal epidural process and offer risk factor analysis for epidural abscess and epidural bleed. Back pain history 3. So lifting furniture over the weekend, mechanism will disappear. Incontinence, none, so that will retire. But the patient has had a fever over the last couple of weeks. Easy to forget to ask if it's not on the list. But now, if the practitioner had anchored on musculoskeletal pain with this information, probably no longer anchored, probably considering an epidural process in the differential diagnosis. Also, we believe that decision support, sometimes critically important, not often, but when you need it, it should be inside the user interface. It should be available in a half a second. And you shouldn't have to pull a cell phone out of your pocket or leave here to go to the internet. So this is a quick consult: spinal epidural abscess, key history, key physical examination, clinical risk and safety pearls, and there's many other resources available here. Now, key element of ED Guidance, this is a search. You just went to the cloud with a search for 20-year-old male and got back guidance and references for that patient. That just gave this practitioner 0.5 of CME. So if this practitioner sees a child with fever, this patient a couple of abdominal pains, a couple of chest pains, very possible that he or she could have 3 to 5 CMEs from this shift, which could be claimed at some later time. Another important issue is risk factors are so easy to forget. The lists are sometimes long, and so we list them. We just don't name the risk factor. We actually list the risk factors so that you can. There's no prior epidural bleed, comma, patient is not on anticoagulants, comma, there's no bleeding disorder, no recent spinal procedures, period. There are no risk factors for spinal epidural abscess, period. And so those will now retire. Back pain review systems. Back pain physical exam. Vital signs have been reviewed, that will retire. Check fever specifically, there isn't one. Back examination is normal, there's no spinal or paravertebral tenderness, period. Now, before we do the neurologic exam, notice that there are other resources are available. If there may be a spinal injury here, it's hard to correlate or remember what part of the body with what part of the spine. And so that's immediately available, again, without leaving the user interface. Or maybe you're looking for a dermatome map, or do you remember motor? Do you remember the deep tendon reflexes? Very difficult to remember. When you need it, it's nice to have it. Or additional non-encyclopedic resources, just what you need for back pain. What is this spinal cord syndrome you're dealing with? Maybe it's anterior cord. What does an anterior cord look like? It looks like that. So clinical decision support inside the user interface. Now, last thing, this may be a neurologic case because it's a back pain case, and so benign neuronormal is not good enough. Looking for a complete examination of the relevant organ system, and because the Nuance platform is able to determine that, neurologic examination is normal, period. Neurologic examination is benign, period. Will not retire that exam. It requires something like a neurologic examination. There's no sensory motor focal deficits. Common deep tendon reflexes are normal. Common straight leg raise is negative, period. And that will retire neurologic examination. And we have, if we're doing this together with our group or our organization, clinical alignment around these critical risk, safety, and quality diagnostic drivers, keeping our patients safe, reducing medical errors. Thanks for taking the time to watch.